so differential, they already talked about leiomyoma. Just one thing about these
किसी EUS
submucosal
images
lesions
तो
is,
उधर होंगी ना projection
uh,
EUS की image तो उधर जाएगी ना
like if you
हाँ ना बस
find
ठीक है
those in esophagus,
ठीक है
90%
okay
chances
so we're
are
starting
it's a
to intubate yeah
leiomyoma. If
so
you
take the
find
scope
those
out
in stomach,
just move it up
90%
and down
chances are they are
अब नीचे करते हैं
gist.
नीचे करते हैं एक मिनट just to get your
Leiomyoma
idea पूरा
usually
नीचे
do
करो
not
yes
ulcerate
so what
on
you
the
need to do is
surface like that,
वो
and they
ऐसे
don't
करके और फिर
bleed.
हाथ
They
से
can
पीछे
cause
करो
the symptoms.
try again
If it's in esophagus, it will
excellent
cause dysphagia, but they
chin
don't
down a
bleed
bit
like that. So usually it's the
chin भी थोड़ा
stromal
सा down
tumor,
कीजिएगा
it's an
move the chin down
aggressive tumor. Aggressiveness on EUS will see that how it looks like, but there are some features which is
you're
show it's
struggling
like
okay
how
try Dr.
like they could be aggressive
Khalid's way so
tumors.
turn it completely
Like
around
we'll
ऐसे
see
हाँ let's
if
try
there is
that
a kind of
yeah
areas of
okay and then now rotate it
an
back
echoic area,
and see if you can tilt
so
it
that
down
shows kind of a degeneration of the tissue there. That is considered
a bit
a
struggling
feature of
still
aggressiveness of the tumor. So, oh,
okay let me have a look
this is a Olympus scope, right?
so what I tend to do
Fuji
outside
wala?
I tend
Okay.
to move
Let's
the
see
scope up
what
and
they
down
did.
chin down please चेहरा नीचे करें ऐसे just ठीक है ना so that you can get
Shahzad, आप mic जो है, can you put that on the right? Because you are going to keep turning to the right.
The mic on the right.
okay
Your mic.
यार ये mic right पे लगाया करो.
yes so can you hear me now
Yes, very well.
so yes so we're just going to try to intubate the patient with this Fuji scope so we were discussing about which way to do it. I'll just do my normal way. So I usually check the scope outside to make sure that it is well oriented. I make sure that the head is square on with the shoulders and the chin is down. Request the anesthetist to put the chin downwards. And then we'll just go over the tongue area just like a normal scope. And I just try to move the hand upwards. Is the patient okay? I think the patient is a bit lighter, so they're just going to probably ये मशीन आप लोगों की तो इसमें ऑटो का बटन है ना दिस शुड सॉर्ट इट आउट सो एक मिनट अभी ना तुम्हें ठीक है ना दिस शुड सॉर्ट इट आउट सो लेट्स सी ठीक है ना लेट्स सी है ना लिखा AUTO let's see okay let's start we'll just see if we can get the scope in yep so that's okay so at this point I'll just see chalo theek hai let's okay so I tend to go directly to the GOJ by looking at the normal endoscopy image you can go and then we'll first interrogate the pancreas area and then we can come to the mediastinum okay because you did the mediastinum yesterday
EUS image लगा दें.
yeah excellent so now that's the GOJ so you should be roughly at 40 centimeters yeah excellent so you are at the yeah that's your lesion but let's forget about the lesion for now we'll come to that in a moment suck up air out of it so you've got a lot of air inside can you see all of that interference is the air
That's the fluid.
sorry
That's the fluid.
no this probably it's a mixture of the fluid will come black and all of this interference is air so if you suck that out
Is there a balloon on the scope or no?
there is.
There is.
I think we're on a bit of a hiatus, so we'll just pull back slightly and now just turn the scope around. Just let's see your movements. Yeah, keep on here. Excellent, that's good movement. So keep on moving around. You can see the structures are starting to come. So that's the image that you want of the aorta. Yeah. Okay, so that keep on turning around so that you can get just a 3D image of where you are. And I'll see if I can optimize this image a bit. Yeah, I'll do it manually.
That's the IEG. Yeah, that's the yoga.
Yeah.
The image looked a little bit better previous settings. So that's the IBC there.
Yeah.
That's IBC.
So this setting, you mean?
I don't know.
Light किया था ना आपने या dark या
Yeah,
light?
this is a little bit better.
Better. Yeah. Okay. I'll keep on adjusting the image and see if we can get it right. Yeah.
Should I advance a little bit?
Sorry? No, just keep on rotating it. Keep on rotating it at this. I'm just trying to see. Yeah, keep on rotating it so that you can just orient yourself. Yeah, keep on rotating it. Excellent. Keep on rotating it. So we're just trying to get the home station, the aorta. I think you're slightly out. You just need to push. There you are. You're coming into position. Can you see that? So that's where the aorta is coming down. So that's your home signal. So are you comfortable with your hand? Just keep it loose. Yeah, excellent. That's great. Okay. So now just move it left and right a bit. So it's like Dr. Gayas was saying, it's a dynamic scan. So it's not one place you just need to stay in. So you can see your aorta. Just bring it into the landing position, coming all the way from the sign of this F going downwards in an angle. And that will be your home station.
Like that.
So yes, excellent. That's a very good, position for it. Again, just move it a bit dynamically so that you can see the top and the bottom of it. Yeah. Yeah. Just move around, play around with it a bit. Yeah, excellent. So yeah. So your hand movements. That's okay. Yeah. Okay. You seem to be doing more of a wrist movement.
Yeah.
Just do a bit of more of a shoulder movement, and just let this rotate as well with you. Okay. And then just go back a bit. Excellent. Just to get a feel of where you are. Yeah, excellent. So can you see it's becoming a bit more horizontal? See if you can make it a bit more, tilted. Sometimes using the little wheel makes it like that. Yeah. Excellent. So you've got a good idea where the aorta is. If you want to confirm it, you can check with the power Doppler. So you can apply that. So that will give you an arterial flow, which tells you, yes, you are in where you should be, okay? So, and obviously the flow there will be positive as well. Okay, excellent. So let's now move a bit down. Your scope is a bit out, so just follow that downwards. And you need to look at the first takeoff, of the vessel, and that will be your celiac artery. So can you see it's blocking down? Stop there now. Now rotate the scope left and right until you get a bigger image of the aorta. Yeah, excellent. Okay, excellent. Now again, you can rotate it left and right. Yeah, excellent. So the vessels are starting to come into play here, the splenic vessels, etc. Yeah, excellent. Keep on pushing the scope in slightly more. Okay.
I'm using the
Don't worry, don't worry. So, but you are in the right place. Now use your, I think you've moved your little wheel. That's why you can't get it in place.
it's in the neutral position.
Yes, okay. Push the scope in. Because we need to be a bit lower down. Yeah, we need to be a bit lower down. Yeah, another couple of centimeters lower down. Yeah, yeah, we'll find that image, don't worry. So let's see if we can magnify this a bit. Yeah, okay. And I will see if I can optimize the image further. Yeah, okay, excellent. So this is your aorta coming down and your celiac axis is coming off. But this image is, you need to just optimize it a bit more. It's quite a bit more vertical. We want it slightly more horizontal, coming at an angle roughly of 45 degrees. Can you see those vessels? Yeah. Yeah, so if we want to put some Doppler here, you can probably see the vessels now here as well. So that's the aorta, the artery coming up, and the splenic vein as well, okay? Yeah, so if I'll just take away the Doppler because it disintegrates the image a bit more, yeah? So I think you may be struggling because of the big mass that's in the fundus, okay? But you've got reasonably good images of what's going on, yeah? So what you're worrying about is by pushing the scope forward. You can just push it forward. Just push it forward by another, yeah. Now you can move it left and right, okay? Now rotate it back and forth to see where you are with the aorta. Okay, so you're directly actually on the pancreas now. You know,
That's the kidney.
that's the kidney. Yeah, that's the kidney, and that's the pancreas. Yeah, but you are on the pancreas. Yeah. So what vessel is this one? If you're not sure, you put the Doppler. We know it's a vessel, and you can put the power Doppler on top of it and see whether it's an artery or a vein. So it looks like a vein. It's the splenic vein because you can have the venous hum. rather than the artery. So let's see if you can find the splenic artery. You did see it just there.
I can see that.
So let's just confirm whether that's the splenic artery or not. So you should have a, can you see there's an arterial flow? So from that you can differentiate whether it's the vein or the artery. That's a very good image. So you've got the splenic vein there, you're getting a venous hum, and here you can get this the arterial pulse. You will be able to see it. Can you see that? Yeah. So we are now sure that you're at the splenic vein and the splenic artery. Okay. Okay, and that may be the PD actually coming up that small dot.
Shazad, we're gonna switch in a few minutes to the other room.
Okay.
So if you can spend like 15 total minutes with each attendee.
Okay.
So I think you have 7 more
That's
minutes.
the
We're
PD.
counting.
Okay. So yeah, that's probably the
that's
PD. We
that's
can
the
see the PD. Yeah.
So
So keep on going. So if you move in an anti-clockwise way, you are going towards the head. Can you see the PD? It's now disappearing a bit. Yeah. Excellent. So that's the fall off of the portal.
Splenic,
Yeah. And now you move towards the clockwise. You rotate clockwise. Keep those vessels in the center, if you can. So to move something towards that way, you just need to pull
pull
back.
out,
Yeah. Pull back. Yeah. Keep on pulling back. Excellent. Excellent. Now just follow the splenic vein. Let's see if you can get the splenic vein right to the hilum of the spleen. Okay.
So for this,
So you need to do a clockwise turn, yeah, and try to keep that in the center. So if you just push it slightly in, you should be able to get in. Yeah, excellent. Yeah, excellent. Keep on following that. Excellent. That's great. That's great. Yeah, keep on following that. Yeah, clockwise fork. Yeah, keep on twist. Excellent. Yeah, so it should be going in the hilum. It's not gone yet completely, but yes, you are on your way. So that's the spleen coming into view now. You can see the
I
spleen.
can see the hilum, yeah.
But ideally you should see it go all the way. So if you keep on turning, can you see it's going into there now? So you can see it, that's the splenic hilum. It seems to be going into it, okay?
Okay.
Okay, excellent. And now you can follow it back. So from the splenic hilum, you can see the tissue of the pancreas from the tail. And then you should be able to see the kidney on the way. Excellent. So try to keep the vessel, so it's going towards your left. So pull the scope out slightly and you should be excellent. Yeah, that's great.
I can see the pancreatic duct,
Barely, yeah. Okay. So do you want to spend a couple of minutes in the duodenum before we go to the lesion? Okay. We'll just do a bit of the duodenum now. We'll go to the duodenal bulb. So this patient had a 5 centimeter lesion in the fundus, which looks like a gist. We're going to take a biopsy at the end.
a lot of fluid in the stomach.
That's okay. Fluid is good.
Okay.
Air is bad. Okay. So yeah, see if you can. So it's like the ERCP. Yeah, excellent. I think you're in the bulb now.
Yeah.
So keep it on the left. Yes, excellent. The top left, and you can see the liver structures. Yeah. Excellent. Now do a slight clockwise. Keep on talking clockwise until your aim is to find the portal vein.
So
Okay.
do you want me to pull out a little?
No. Keep it there. So no pulling out here. So it's not like ERCP. In D1, you actually have a loop in the stomach. So you will be examining it with the loop. Yeah. Okay. So your aim is to find the portal vein, which will be another structure coming from the opposite side down and a landing pattern. Okay. Okay. So I think you're further down. That looks like the kidney to me. Yeah. Okay, start rotating. Are you in D1? Yeah, I think you're too far in now. Just pull back with the scope. Let's see where you are. Yeah.
I think I'm in the stomach.
I don't know. If you just pull back slightly, I think you are still in the duodenum, but just fill some air in so that you can see where you are.
I think I'm in the stomach because I'm at 60.
No, I think you're not. So just pull back, yeah. And now pull in air and then go again, like you did last time. Yes, that's okay. So excellent. Now it's very clear, isn't it? Yeah. So just excellent. Just stop there for a second. Now see if you can find the portal vein. Excellent. Now do a clockwise torque. So you're doing an anti-clockwise. Do clockwise, keep on going, and your hand should go up, further up, big movements. Yeah. Yeah. Keep on turning. Keep on turning. So I think you reach the kidney very quickly.
Back to liver.
Back to liver. Yeah. Just let me have a quick look. Where are we? Why are we not able to? I think that's the mass actually that you are, that you may be. There's one further down. Yeah. I'm just trying to get some good image.
The large mass that
Probably. So this looks like the vessel that you have, isn't it? And that's the CBD. Yeah. If you see it, yeah. You take it. Take hold of it. Yeah. And can you see there's something in the CBD?
looks like a sludge.
Yes, we've. So the portal vein is down here. I don't have a pointer here. I don't think we've got a pointer here on this one. So that's the portal vein. Sorry, and down there. Do you have a pointer here on this?
Sir, it is down. No.
That's the CBD.
That's a CBD, yeah.
And the one above it? Like,
I think it's just tissue and the duodenal folds that are coming up with.
Measurement.
No, that's not it. Okay, sorry, I've got a piece here. Okay, so just follow the bile duct. Let's see if you can trace it all the way down.
I think, yeah.
Khalid bhai, you were saying something?
You're looking at it and just need to make sure that it's a bile duct or a gallbladder.
Okay,
So,
so let's just follow it up from the top to the bottom. Let's see if you can bring it down. So clockwise rotation.
the way it looks more like a gallbladder, not the bile duct.
Yeah, you may be absolutely right. Yeah.
I
And the
think
amount
a
of
bile
sludge it
duct
has.
is underneath.
Okay, should we go to the lesion now?
Yeah.
Just bring back. We couldn't figure out the pointer here. Yeah. Just can you see the lesion endoscopically? It was in the fundus somewhere, wasn't it? It's a 5 centimeter, so you can't miss it. Yeah.
There's the one.
Yeah.
Yeah.
Okay. Excellent. So let's just have a look at that. Yeah. Try to bring it in the center. So it's on the right of the screen. So you can pull the scope back, and will come in the center. Yeah. And you can see there are multiple hypoechoic areas as well. That goes with the gist as well. It being a gist. Just rotate it all the way. So it's close to the other organs. Yeah.
Yeah.
So make sure we don't stick a needle in those. Yeah. Excellent. So I think you've pulled 2 back. So push it in further. There it is. Yeah. Push it in further. The scope in further. Yeah. Excellent. That's a good place. So at that point, we'll just see whether there's any blood vessels coming here. So we'll have a 22 FNV, please. Okay.
So we can appreciate the deeper layers. There's
So it's difficult to
Yeah.
say on this size whether it's, what you're trying to say is that if you were really wanting to see the layers, you need to go to the normal and then to trace it up to, as we were discussing.
but this is the normal.
So you can see this hypoechoic area is the muscle layer that you can see. Yeah, so see if you can trace it up to that mass.
So here's the mass.
Okay,
Like,
so-
can you appreciate the one? Yeah.
So I can see the mass, but I can't actually appreciate whether it's coming from that layer. Well, probably bottom here, yes. Have you got the needle? अच्छा तो अभी कितनी देर
इनको जो है ना इसको केस को डिस्कनेक्ट कर दें, हम अगला केस जो है ना प्रेजेंट
Okay.
करने लगे हैं.
Okay, that's fine. Thank you. हाँ. Ready? अच्छा. I'm guessing
ये
then.
stable position.
हाँ, that is good. So I'll do it.
Yeah.
Yeah. Although I think you are much capable of doing the biopsy as well. But
शहजाद आप जो है ना वो ख़त्म कर दें केस को.
okay, I'm just trying to take the biopsy and then we'll finish. Thank you. Give me the biopsy also. So when I do the biopsy, I just try to push this forward to see whether the needle is out or not, so that you are not damaging the scope, and then you can pull it back.
Why do you want to pull it back? Like,
Because otherwise it's too far out, you see. It's too far out. You'll see, look, when I am at this lesion, if it's too far out, then, it won't be very effective for me to do the biopsy. So I want it close to the scope, but not inside. So can you hold the scope there? Yeah. So I've just stabilized the lesion there. I tend to use the...
how do you know that it's not inside, like
What?
back and inside? Like,
Okay, so if you move it, you can see the tip. You will be able to see the tip. Okay, so can you see the tip
Yeah.
there? Yeah. So I know that it is outside. Can you see the tip here? So it is out. I know for certain. And then with a bit of experience as well, you tend to know that those further few millimeters I can pull out. But for this one, I'll keep it out. Can you just anti-clockwise talk? That's it. And I'll just make sure there's no Doppler. So there seems to be a small vessel here. We'll just take it out, yeah. Idhar pakdega. So make the tip a bit sharp, okay, so that it can, penetrate. And now we are going to go in, yeah. So we are pretty good there. चलें जी, ये सक्शन लगाइएगा इस पे ज़रा ये निकालें और इसकी एक पिक्चर ले लेते हैं अगर पता नहीं स्टोर कैसे होता है इसमें I don't know. Anyway, so it's nice and soft, the lesion. Yeah. On them.
does it make a difference with a 10 cc or a 5 cc?
No, it comes with one.
Fine, just trying
ये
to
इसके
figure
साथ ही
out
आता है needle के
321 and
उसके
what is
पैकेट
that?
के अंदर ही आता है.
What we
For,
can do
for the suction width, overall not really, but there are some people that say that if you are biopsying a lymph node, then if you have too much strong suction, it will produce more blood rather than cells. So in that you have got an argument of going halfway. But I don't think there are any studies to say कि यार आप इस पे 5 लगाएं उस पे 10 लगाएं. It's like a personal preference thing. You want to play around while? Do you want to play around while he's getting the biopsy? आपने कभी biopsy की? Just let's see if we. I'll just hold it and I'll let you just to feel the jab, how it feels. ये soft tissue है ना सारा. तो देखें इसमें centrally इसका सारा इसको describe कैसे करेंगे? एक तो इसका size measure करेंगे आप. Pause करें इधर से. इसको press करें, pause करें, freeze करें. ठीक है, अब size measure का बटन दबाएं. ठीक है ना, अब इसको नीचे लाएं इस जगह पे या ऊपर ले आएं. हाँ, यहाँ पे enter का बटन दबाएं. ठीक है, इसको नीचे लाएं. नहीं, एक कहाँ गया वो? हाँ, इसको enter का बटन दबाएं.
नहीं, I think कोई और बटन है. Enter ही है.
हाँ दबाएं.
वो
नहीं, एक
खत्म
उल्टा
हो
है. ये होगा नहीं, ये तो बैक है. अरे एक मिनट देखो, ये कैसे खत्म हो जाता है?
ये तो नहीं है.
नहीं, नहीं.
ये तो मेन्यू पे चला
नहीं
जाएगा.
नहीं, ये तो यार ये बैक है. अच्छा नहीं, ये फ़र्क है इसका, उल्टा हुआ हुआ है. ये बैक और एंटर भी उल्टा हुआ हुआ है. ठीक है, तो ये तो खैर मैंने गलत कर लिया. ये यहाँ से आप करके you just measure it.
It's somewhere around 4 centimeter.
So 37.37 millimeter. ठीक है ना, and then once you have done it, you just do it like that.
ये शो करता है कि नीडल की डायरेक्शन और बाकी चीज़ें.
क्या
इसका
चीज़?
पॉइंटर कहाँ पे?
Pointer ये
F.
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 है हमेशा ज़्यादातर इसी साइड से नीचे आ रहा होता है. ठीक है ना, you can
Doppler.
डॉपलर हाँ इधर थोड़ा सा करीब खड़े हो उसके हाँ अब इसको ये दबाएं
ये
सी
CF
एफ
है,
सी एफ
okay.
ठीक है ना कंटिन्यूस फ्लो नाउ यू आर चेकिंग नाउ यू कैन इसको लगा के ना अगर ये
हाँ,
इंटरफेरेंस
I can,
आ रही हो तो
yeah.
यू कैन रिड्यूस और इंक्रीज द इंटेंसिटी ऑफ इट
ठीक है।
ठीक है ना और एक पावर डॉपलर होता है वो होता है देखने के लिए कि आर्टरी है या वेन है ठीक है ना यू कैन डू दैट बाय सेलेक्टिंग दैट वे तो पॉज करना आना चाहिए आपको प्ले करना आना चाहिए अच्छा दिस इज़ द गेन देखें ब्राइटनेस ठीक है ना उसके इर्द गिर्द आप इसको कम ज़्यादा करके आप यू कैन एडजस्ट इट और ऑब्वियसली दिस वाज व्हाट वी वर डिस्कसिंग आपने किस लेवल पे करना है
Describe it like a non-homogeneous solid mixed architecture.
तो आप heterogeneous
heterogeneous.
mixed
Uh,
architecture
Shahzad, we can see this is the same one, right?
yes
There cannot be two just same size.
no no
Okay.
so it's a very large lesion and
We can wash that while can we bring that back until we start the next one?
yeah.
उसका हाँ जी बायोप्सी वाला करवा दो जो
needle आगे जो दोबारा so we were just trying to describe the lesion we measured it it looked fairly large roughly 5 centimeters or so we'll try to measure it again
हमें दिखा दो यार कमरे में अब देख रहे मशीन चलती कैसे है बाद में ऐसा हो कि हम लेटे हुए हैं उस बेड पे और हमारे ऊपर चल रही हो
हाँ बाहर से लेंगे आप आइए तो नहीं आइए so it's like 4 centimeters चलें जी why don't you put
Shahzad, we can hear you again. So the other case did not start yet. We're
Okay.
back at you.
so take it out and put it in yeah so it's a 4 centimeter heterogeneous mass and it was quite soft when we put the needle in to us it looks like a gist
शहजाद आप खुद सैंपल करके दिखा देंगे
जी जी मैं sample I was just wanting him to put the needle in and I will do the sample you know just to give him the idea how the sheet feels when it comes out so which is one of the probably the most important thing especially in our setups because our scopes tend to get damaged and Dr. Saad was saying that if a needle is being reused there's a more increased risk that it might get stuck in the bottom end
एक सेकंड रुक जाएं और ना नीडल डालें so you see how the sheath is already so many centimeters out the recommendation is to have it no more than 2 centimeters out before you put the needle down so sheath को जरा पीछे आप Shahzad just show him how the lower dial जो assistant है उनके अपना हाथ हटा दें जरा। just to see for everybody कि भाई there are 2 dials one for the needle and one for the sheath
उनको वहाँ से देखने में कैमरा से can you see it now
हाथ हटा दें
हाथ हटा दें
I'm right there. Yeah.
So we can see now, so just for the trainees, the lower dial here is the distance the sheath will come out of the needle. So you don't want the sheath out too much when you put this needle down the scope. Usually keep it less than 2 centimeters. Then put the needle down and lock it into the scope.
Okay.
And then under visualization, you can then advance your sheath. If the sheath is sticking out too much, then it's going to hit the elevator of the needle and get bent and cause damage to the scope.
Have you got it in? Yeah, excellent. So biopsy-wise, as I was saying,
So the one point, that's one point. Second point is that every single needle, when it's nicely rested on that lock, before you rotate it, if the wheels of that are facing toward you, it goes 3, 4. And by the time it is nicely locked onto the scope, your wheels will be on the right side of it.
It's
So
what
instead
nicely
of like
rested on what? Nicely rested on what?
the
ending
elevator.
up anywhere in the other place.
Then the elevator should be away.
Nicely
right?
sit
And you
it
use it
on
when
the
you want to
channel,
move
working
it
channel,
Move it up and
inside
down.
the-
rotate it 3/4 degree, and that's when it gets locked onto the scope. So what I do is that's every single needle. That's how they made it.
So you can
So
see
if
the needle now.
wheels are
It will be
facing
coming
towards
out.
you, it's nicely rested, you rotate it, and the wheels will end up to the right side.
There you can see it, yeah. So the other point I was trying to make is that sometimes, somehow these needles, you know, they can be deployed within the channel. And what I found to be the safest approach is to unlock the lower wheel and move the sheath forward. And you can either endoscopically see it or on the EUS. So you can see the needle now on the EUS. So you're pretty safe now. that the sheath is out. Now that's a bit too much out, and once you've reached that point, then you can pull back slightly so that you're not too much out. But that now gives me the confidence that the needle is going to be deployed outside the scope. So I'll just request my assistant to give a bit of an anti-clockwise torque. I've positioned myself well on it. In this particular case, I have locked the wheels because it will give me my stability of putting the needle in. I've selected an area. I'm going to put some Doppler there to make sure that there are no large blood vessels. Small blood vessels, to be honest, I don't bother that much about, but there shouldn't be any large blood vessels there. And I can't see any. So at that point, we're going to take the tip out slightly just to make the needle a bit sharp, and then you can release the big knob. Some people, select it to the depth where they want to go, but with experience, you don't actually need that. If you're starting off, then that might be a good idea. Just hold it there, please. I'm going to reposition it again and just check the Doppler again, and then we're going to see if we can enter. So the needle is coming at that angle. So a quick jab into it, and we are there. Can we take out the swab? So we'll do a slow pull technique in which we are just moving out slowly. Slowly. So keep on going. So we're just moving, trying to fan through this lesion. Yeah. Yeah, take it out. Yeah, excellent. And we've got good sample there, but that's fine. We can take it out. I tend to put a bit of suction as well on top. I understand some people in the group do not put suction. Yeah, take it out, yeah. And put the suction on, yeah. How was the sample previously? Piछला sample ठीक था? हाँ. Yeah, so I just put suction on, a few quick jabs while the suction is on, and that should do the trick of getting the sample. So I've locked the big wheel up, and we'll just move the needle.
So we might switch to the other room, Shahzad.
Yeah,
So
okay.
we won't. Let's see what that shows. So other thing is here for candidates, if you look at this tumor gist, like you see those black spots, that shows the areas of necrosis in there. So that's a component that just looking at it without even doing a FNA, that's a component of an aggressive gist. These are the ones that bleed, they can spread.
और दरमियान में आपका आ गया
They have a
ये
more mitotic
pancreas.
activity.
अब पैंक्रियास की साइड पे ये क्या रखा हुआ है?